All right, welcome back to a plenary session and drug development exclusive. I'm joined by Timothy Olivier, by Alison Haslam, by Miguel Zugman, and many others from our laboratory. We're going to talk about the top ASCO abstracts. This is prior to ASCO. We're recording this on the Wednesday before ASCO. Timothy has put together these slides. We're going to talk about 7 abstracts that we think are worth looking into, and even without seeing the full results, we're thinking about the questions we have, what's going through our mind, what we're going to be looking for. Let's get started. All right, these are the big ones. We've got LAURA, which is maintenance osimertinib in stage 3 lung cancer. Oh, if you liked ADAURA, you're going to like LAURA. We have Destiny Breast 6, which is giving trastuzumab deruxtecan right up front as the initial chemotherapy. We have Telehealth, palliative care, because who wouldn't want to do more things by telehealth? We have Evoke 1, which is secatuzumab govitecan versus docetaxel in second-line lung cancer. Good old docetaxel, once again, that control arm. It'll be that control arm for another 100 years. Nadina, neoadjuvant ipi-nivo, melanoma. We have Transmet, which is a trial of surgery versus chemotherapy alone, chemo plus surgery versus chemotherapy alone in colorectal cancer with liver mets that are unresectable. And we have a Proton non-inferiority study. So it's a good blend here. I think we've got some breast, we've got some lung, we've got some surgery, we've got some radiotherapy. Timothy put this together. I think he's done a nice job. Let's see what we can find here. Many others. Yeah, we'll put out more videos as this goes on. So subscribe to the Drug Development Ladder if you want to stay abreast of what we're thinking about around ASCO. All right, let's talk about osimertinib in stage 3. Now, as we all know, osimertinib has randomized control trial data in the front line based on FLAURA, where it went up against the older drugs, erlotinib and gefitinib, and it has a whopping PFS benefit and later had an OS benefit in FLAURA. That justified its use as the preferred frontline treatment option for recurrent or metastatic non-small cell lung cancer with EGFR mutations. Then, of course, the company ran ADAURA, which is a great randomized trial where you take people with adjuvant lung cancer and you randomize them to upfront osimertinib in the adjuvant setting versus a control arm where about half of them never got osimertinib, which is an unethical and delinquent control arm. And then lo and behold, there was an overall survival benefit. Ergo, the company thinks you should give it to everybody. The only people they didn't think should get it were the control arm participants who progressed. They didn't seem to care about those patients, but they care about giving it now even to low-risk, early-stage lung cancer. Wonderful study that was. Now we're looking at stage 3. This is it, the LAURA study. Stage 3, typically unresectable. This is the space that I think Pacific came in, except it's EGFR mutant positive, and they're going to randomize people with stage 3A, 3B, 3C, non-small cell lung cancer, curative intent, to concurrent chemotherapy, radiotherapy, or sequential chemoradiation. And it's going to be a 2-to-1 randomization, stratified by in China, out of China, and they're going to give people osimertinib in the follow-up period or placebo. They're going to follow up all these endpoints. PFS is the primary endpoint of this study, and looking at all these other things. The sample size, this is the initial sample size Timothy found. I don't know what the actual sample size is going to roll in at. I'd be surprised if it's as low as 200, but we'll see. All right, let's talk about this for a second. What happens to people who are EGFR positive in stage 3 setting? Should they get durvalumab? I think I'm actually with most people who globally who think that if you're mutation positive, you shouldn't get durvalumab, that there was no clear evidence of benefit in that subgroup. Although, strictly speaking, I think the current guidelines do not advise against it in the United States. And for that reason, one could argue, should the control arm have gotten durvalumab? Meanwhile, the intervention arm shouldn't get durvalumab, obviously, because it'll potentiate the EGFR toxicity. Any more thoughts on that, Timothy?
No, I think it's really the space where osimertinib has no indication for now. There's ADAURA, there's FLAURA, and now we have LAURA. And yeah, there was a subgroup analysis from Jarushka Nadu. It was not pre-planned, but it was against a role of durvalumab in EGFR mutant population. It was a subgroup analysis from Pacific.
And we have some unpublished data that we're going to put out soon about whether or not these drugs work in mutation-positive stuff. But yeah, I think it's fair to say that PD-1 inhibitors don't work in mutation-positive non-small cell lung cancer. Of course, the company has already celebrated. They've popped the champagne. There's an overwhelming efficacy benefit. And here's what we're looking for. Okay, number 1, proper staging. Did these patients get PET-CT and brain MR? Timothy, you want to talk about that for a second?
Yeah, I have the feeling that we will have the same question as we had for ADAURA, mainly. So if if people are understaged in a sense, so they are already metastatic, but you didn't make the stage that you would have done today, you are favoring your experimental therapy because people are already metastatic, and so you know that osimertinib will be, more will have more efficacy. So this is a classical question, and this was a point in ADAURA, and I suspect this will be a point in LAURA.
Yeah, I think this is a key point that people forget, which is that the trial has to provide U.S. level of staging up front. If you have occult metastatic disease, we already know those people with metastatic disease benefit from osimertinib up front. So we don't want occult metastatic. We want actual stage 3 people. That means you have to get negative brain MR. It means you have to get PET-CT and exclude distant disease. I suspect they didn't do that because they didn't do it in ADAURA. They didn't do it here. And I think that's a form of cheating. All right, what's the rate of patients not progressing in the control arm? So the point you want to make, Timothy, is what percent of people are already cured?
Yeah, so to me that's very interesting because we know it's not the same population. Classical, most stage 3 cancer, there are younger people, more female, more non-smokers. So I'm very interested to see what happens in the control arm.
All right, let's go on. Rate of crossover. This is the key question. Of course, everybody on the control arm who progressed, 100% of those people should have been getting osimertinib. And the relevant question, of course, is not progression-free survival, but whether or not you have to give osimertinib upfront versus giving it on the back end to people who progressed. So overall survival, or at least PFS2, is a much preferable endpoint. We need 100% crossover. I suspect we're not going to get that because we didn't get it in ADAURA. I think that is delinquent when that is not provided. They may receive.
Yeah, so
the study will be broken.
Yeah. You can just read it. The wording is unclear, and I really suspect that the crossover will be suboptimal, like in ADAURA.
Yeah. And finally, breakdown of PFS events. By that we mean you need to tell me among the PFS events how many are distant relapse, how many are local failure, how many are brain mets. You need to give a breakdown of the PFS events. This was written about by Anushka Walia and I in Nature Reviews Clinical Oncology in a lengthy review article on the topic. And finally, post-therapy pneumonitis. What is the rate of post-therapy pneumonitis in both groups? Because down the road, somebody may play around with the PD-L1 inhibitors, and we'll see what happens having gotten so much OSI on board. And I think the other thing that we forget about this whole thing is if you blow all your TKIs up front in these adjuvant populations, what are you going to give the patients who do recur metastatic disease? And what's their quality of life going to be on those chemotherapies?
And even on the biological point, I mean, we don't know. Maybe we are selecting for some other clones that will be resistant. Maybe so. I think there are many open questions yet. And you're right. We don't know if the timing, maybe the timing is affecting the biological evolution of the tumor.
Let's go to the number 2.
Yeah.
Trastuzumab deruxtecan, very active drug in HER2-positive disease. Now we have data before in the relapse refractory setting for HER2-low population. They're going further. With DESTINY-Breast6. This is a study that includes people with HER2-low, IHC 1+, 2+, and ultra-low, all the way down to 0. Hormone receptor positive. You had to have progressed through endocrine therapy, and you could have gotten cyclin 4/6 kinase inhibitor therapy, but you have to be chemotherapy naive. And of course, they randomize you to trastuzumab deruxtecan versus physician's choice, which means anything you would give in. Nope. It doesn't mean anything you would give in clinic. It's a restricted choice. It's like when I take Timothy out to dinner and I say, you can order anything you want off the kids menu. Anything you want, but you can't actually order anything you want at this restaurant. And that's what they've done here. They've got Xeloda, they've got Taxol, they've got Abraxane, which should be in the toilet because it's inferior to Taxol, okay? What they don't have, of course, are some other options we're going to talk about. It's an open-label study. That's a problem. It should have been double dummy study, in my opinion. There's a statistically significant improvement in PFS per the press release. Thank you, investors, because if it weren't for investors, we wouldn't get any inkling of the data until after the conference. Of course, trastuzumab deruxtecan is known for ILD. Those of us who've given it in the community, we see a lot of ILD. I've seen people giving this for lung cancer, and mostly what I've seen is the ILD, not a lot of the responses. What to look for? This is your point, Timothy. No anthracyclines in control arm. You want to take it away?
Yeah, I mean that because anthracycline, of course, is a key element in the treatment of breast cancer. But I mean, many options are missing, and when I just check the NCCN guidelines and I just check the number of options, I was really surprised of what they choose actually. So I think these restricted choice are not a good thing, and they are making suboptimal control arms. So this is also making the second point: how many patients actually never received anthracycline before? That will be a key question. And I hope we will have some better patient characteristic report than in DESTINY-Breast4, where it was very, messed up. We wrote about that, and it was very difficult to find precise patient characteristic table.
I did a video on that. It had piss poor reporting, in my opinion, in DESTINY-Breast4. I suspect it'll be poor here as well. I agree with you that this physician choice is a misnomer. It should be called restricted or limited choice. Timothy has a whole paper on physician choice. It's often a restricted choice, and often they omit the most potent agents, okay? That's a way of gaming the trial. You can run, some people tell me you can't run a randomized trial against true physician choice. Yes, you can. It's a very simple study design. Investigator choice versus whatever the doctor wants to do. It can be done. There's no rule that says you can't do it. Run it in the United States. You'll get some good choices in the control arm, and you'll get a much cleaner study. HER2 low, how do they define it? You want to say it?
Yeah. So HER2 low, I mean, this study actually, it's not HER2 positive nor HER2 negative. But, what is really the definition? As soon as you see one, staining, will it be HER2 low or ultra low? And I think this is really a moving field. And at some point, I think it will be interesting to see how it compares with previous studies. The question here is how many patients will be included in this definition? And
also there could be an interaction between HER2 positivity and benefit. And the company will do everything they can to provide nested subgroup analyses rather than adjacent subgroup analyses.
Yeah.
We want to know the precise place where there is no benefit versus there is benefit, not to have it lumped in with higher HER2 positivity. This is something that Sunny Kim and I have written about in the past. Informative censoring, of course, this is the problem. It's open label, suboptimal control arm. People on the control arm are going to drop out early. How many people drop out? And who drops out? Does the poor person in Eastern Europe drop out when they get the control arm? Or is it the wealthy, connected person at Memorial Sloan Kettering or Anderson that drops out? And if you have dropout that's not at random, that's based on the characteristics of the people, which very likely is the case, you're going to get informative censoring that will taint your PFS estimate. It violates the Kaplan-Meier assumptions. We've talked about that at length. Breakdown of PFS events. Again, I want to know how many events are of what characteristic and the toxicity. All right, let's do the palliative care. Telehealth palliative care. Now, palliative care, of course, is a good thing. We all like palliative care. This is a comparative effectiveness trial of early palliative care versus telehealth versus in-person. Okay, great. Just what we want. More Zoom. But I think Zoom has some advantages. It can be convenient for people who are at home, particularly people who have cancer. Less having to come to the hospital is a good thing. This is a prior study that appeared in the New England Journal, early palliative care versus not in non-small cell lung cancer. Everyone celebrates, of course, the overall survival results of the study, and that p-value is in fact numerically significant. The thing that they don't say enough that they ought to is that this was not the primary endpoint of the study. It was a secondary endpoint. I suspect that when you get a statistically significant result in a non-primary endpoint, you have both types of error at risk. You could have failed to detect a significant difference. But when you find a difference, it's very likely to be exaggerated and or spurious. What's my takeaway? I support early palliative care. That's great. I think a great oncologist can deliver it. But I'm skeptical that it actually improves survival. And I think these data in isolation are not sufficient to make that claim. This is, of course, a randomized control trial taking non-small cell people, telehealth versus in-person palliative care, follows them for patient-reported measures. And the primary endpoint of this study is whether telehealth is equivalent to in-person palliative care based on quality of life measurements on one form at week 24. When you talk about equivalent studies, you typically talk about tight margins. It's a subset of non-inferiority studies. I want to see what the margin is, and I want to see what they find. So what to look for? These are awaited and interesting results. They need to be contextualized and tempered by the fact that probably the original study didn't show a survival benefit, but that's okay. You don't have to have a survival benefit if it makes people feel better. And my point here is I would have much rather see them power their study for superiority of quality of life. It's better to stay home. Show me that it's better rather than show me that it's equivalent. I think that that's too low a bar. I mean, ostensibly, they're doing this as an equivalent study because they think there's some additional benefit to staying home, which I like to stay home too. That benefit should translate into quality of life. So I think they could have directly measured it. Let's talk about number 4, docetaxel second line. As we all know, even though other drugs have beaten docetaxel for both PFS and OS, we still use docetaxel on the control arm. That's an interesting choice. This is the latest such study, sacituzumab govitecan versus docetaxel.
No, you were saying that there are many other options. I mean, there have already been trials studying other combination that were shown better than docetaxel.
Yeah. I mean, ramucirumab docetaxel has an OS benefit. So how does anyone justify not administering ramucirumab? Anyway, here they somehow found a way to do that. This is Evoke 1. EGFR and ALK testing is required. Testing of other actionable recommendations is recommended but not required. And if you did have an actionable mutation detected, you have to get at least one of those therapies. And if you didn't, you don't have to get any. So to me, this is kind of a shady feature, which is that you could take a ROS1 patient and never give them ROS1 drugs and put them on this study if the doctor happened not to send testing. The same people... Yeah?
No. Before moving to the next slide,
Yes.
I will have one thing to say.
Okay.
Move on.
The same people who argue that we ought to test everyone and that practices should have universal testing don't want to have that built into their trial. Why not build it into your trial and practice what you preach? What's your point, Timothy?
No, just to move to the next slide, I think there is one good thing in this trial is that the primary endpoint is overall survival.
And it wasn't met. It's a negative study. And what do you think they're going to talk about? The spin cycle. A numerical...
Worry about that. I worry about that,
A numerical improvement in OS favoring sacituzumab govitecan was observed, including in patients with both squamous, non-squamous, is consistent, well tolerated. Oh, numerical. Numerically improved, but not statistically significant. That sounds bogus to me. Oh, a 3-month difference in OS was in the subgroup of people non-responsive to the last anti-PD-1 therapy. Well. Oh, you found a subgroup. Well, good for you. People who wear blue shirts and who eat donuts on Wednesdays had a 6-month benefit. Did you know that? So we can all slice and dice this and look for subgroups with benefit. It's pretty meaningless in my mind. And it is embarrassing that they're doing that. I mean, I think delete this shouldn't be allowed. What to look for? Spin cycle. Suboptimal control arm. Yeah, what do you think? Docetaxel is not appropriate.
Yeah.
Rates of censoring. How about the fact that you're not screening for all the mutations you tell us that we have to screen for? I think that's an issue.
Yeah, you're
Toxicity
right.
profiles. Ipi-Nivo. All right, this is your favorite thing. This is yet another randomized controlled trial of neoadjuvant drugs versus adjuvant drugs. So this introduces some interesting things. Timothy, why don't you talk about that?
Yeah, it's a highly expected trial. So it's an open-label phase 3 trial enrolling patients with resectable stage 3 melanoma. Maybe next click. And can you just... Yeah. And so randomization 1-to-1. So Ipi-Nivo first. So there is 2 times Ipi, 80 milligrams, Nivo 240 milligrams, then surgery. And in the other arm, you have surgery first and then nivolumab adjuvant. I think what is interesting, when you got Ipi-Nivo first and surgery, depending on your response, you will have no further treatment or an adjuvant treatment if you were unresponsive or deemed to be poorly responsive. So you will have further Nivo or BRAF/MEK inhibition. So the design and EFS is a primary endpoint. So the design is shown again on the next slide, but you can go fast. So I think the thing to look at, because we made a paper on the SWOG 1901 trial, and I think the points about censoring and how many patients won't be able to undergo surgery is a very important endpoint. What were the reasons? Toxicity, disease progression, because in a sense that's really the key issue with neoadjuvant strategy. Maybe you won't be able to do the surgery if there is a disease progression. I think this is a potential issue. If you click on it again, so de-escalation trial, I don't think so, because even if there is one arm when you just give Ipi-Nivo, then surgery, then no further treatment, in all the other realms, it's not really a de-escalation trial to my understanding. And also, that Ipi-Nivo has toxicity and maybe long-term toxicity, so I think it will be very important to see. And the last point is no overall survival benefit to date in adjuvant trials in melanoma. I think there will be an update on the BRAF/MEK, one of the BRAF/MEK inhibitor adjuvant trial. Maybe they will show an overall survival benefit that is statistically significant. I don't know. But to date, there is no such benefit. Yeah.
It's very interesting to me. The other thing that's interesting that I didn't notice until we started recording is that complete responders will have no further therapy, but others will get either IO or BRAF/MEK. How do they decide who gets a BRAF/MEK or IO?
That's also interesting. So those who will receive BRAF/MEK are those who are BRAF mutated. I don't understand really why, but yeah.
Well, I guess they're saying that they have another option and they didn't respond to IO already, so they're probably not responding.
Yeah.
It's an interesting study design. And the real question I have is that if you get all this stuff and you relapse, what do we treat you with? Dacarbazine, prayer? What do we do after all this? TIL? All we have left is TIL and prayer and dacarbazine. What's left? You get all this adjuvant, and then 2 years later you present with, spinal mets. What are you going to give the person?
I think you can re-challenge some of them, of course. I mean, it depends the timing, but yeah, it's a good point.
I don't know. Maybe the response rates will be much lower, at least for the IO, and for the BRAF depends on if the clone grew out. But I think it's an interesting question that maybe as we think about these drugs, EFS is not really the greatest endpoint, and we need to look at some further endpoints that account for the fact that you may sabotage your treatments upon metastatic progression. I'm also curious to know that if you have CR, if you never recur, like is that a cure rate or not?
Yeah. And how many patients will be CR? That's also.
All right, curing patients with liver transplant. This was a provocative abstract. The surgeons finally get involved. Yeah. Chemotherapy and liver transplantation versus chemo alone. These are people with colorectal liver cancer, but it's unresectable. So it's unresectable, and they're being randomized to chemotherapy plus liver transplantation versus chemotherapy alone. The primary endpoint is 5-year OS. The study was powered to detect a 40% difference in OS from 10 to 50%. Okay. That to me smells like a power calculation that you run after you see how many people you can enroll. You're like, listen, guys, we can only enroll, 50 people. So what power calculation allows me to enroll 50 people? And then you ask the statistician. And lo and behold, they only enroll 50 people per arm, and they actually get exactly what they wanted, 60% versus 13%, significant p-value. There's a per protocol analysis, but that's useless. You can put that in the trash can, but they're in IIT is positive. So what's not to like here, Timothy? They reached for the stars and they got it. And, this was the place where they had 40% of people were ultimately disease-free. So it's a new standard option. Okay, if you have livers abundantly available, it's a standard option. What do you think, Timothy? Too good to be true?
Yeah, so to me it's very interesting because as you really said, you design a study with very huge assumptions that are, honestly, to be honest, there are huge assumptions of better efficacy. So you can have a small sample size, but when you have a small sample size, you can have fluke results that will be just the design you were chasing. So this is really, to me, the main point of this study, I think, and the conclusions are so strong. I'm a bit worried about that. Yeah.
Was this study registered on clinicaltrials.gov?
Yeah, I think so. Yeah.
Was the original statistical plan logged before they ran it?
I have to verify that.
Yeah, I want to double check that. While we give some huge statistical assumptions. Yeah, I think that's my question, the statistical plan. I mean, in a perfect world, if livers weren't a scarce resource and if you had a little bit, better sample size, I think it's reasonable to consider this. But I think, this is tough. I mean, honestly, what does this smell like? This smells like this is what rich people will want based on this study. Every rich person will get it. Every poor person will not get it. That's what's going to happen here. This is an abstract for rich people in certain countries. And in certain states, in this country, actually, the availability of liver is much more in Tennessee than it is in California. There's a lot more livers in different parts of this country. All right, last abstract. Proton versus photon. See, a photon is something that we've been doing a long time. A proton is something that we invested $100 million in, and we have to find a way to justify after the fact. And we have a randomized controlled trial of protons versus photons in head and neck cancer. And the primary endpoint here is PFS. Okay, it's a non-inferiority study. The upper bound, the delta or margin, the upper bound hazard ratio that's considered non-inferior is 1.535, which is literally the entire block. You're parallel parking a car on the entire goddamn block. This margin is so unbelievably inappropriate. It's so big. Everything will be non-inferior. I'm non-inferior to Usain Bolt at running the 100-meter dash if the non-inferiority margin is 25 seconds. I guarantee you, within 25 seconds when he finishes, I'm crossing that finish line. And that's what they're doing here. How do they justify this? It's ridiculous. All right. Of course, their actually observed PFS is upper bound 1.35, which is still accepting an extremely high rate of death. To me, it's crazy to see margins that are bigger than the benefits of most drugs we routinely approve. But they're going to conclude non-inferiority. And here's the kicker. The secondary endpoints favor protons, they claim, because there's less G2 placement and there's fewer people who lose more than 5 pounds. But the problem with these two analyses is I think this is not blinded. And if it's not blinded, I worry that the doctor may be less likely to put the G-tube in the person they know is getting protons. And I worry that there may be other sorts of supportive care differences. Also, a 5% loss of weight that goes from 14 to 24%, that's a very marginal difference. And both of these are marginal differences, and I worry that one is extremely bias susceptible. That you're less likely to put a G-tube in somebody who you think is getting protons. For that reason, I wouldn't put a lot of stock in these. They're not the primary endpoint of the study. What justifies non-inferiority here? I think this would be a lot better if the study actually powered itself for superior quality of life and the secondary endpoint was non-inferior OS with a tight margin. Why would I do protons if they're non-inferior and might have a secondary benefit? Show me superiority in quality of life, and then show me that it's non-inferior in terms of efficacy, and then show me that it's cost-effective, which you're still light years away from. What are your thoughts, Timothy?
Yeah, I mean, I think that's really important to have trials to prove that proton are better, or at least as good as photon. But I think here we are not convinced. I really feel the toxicity looks similar to me, and all the points you made.
Yeah, I mean, if you know what they're getting, I think you can't look at G2 placement as an endpoint, unless it's blinded. Maybe it's blinded.
Let's see. It's. I don't think so, no.
Yeah, we found no evidence that it's blinded. I would think they'd want to make that known. All right, those are the top abstracts. Laura, yep, I know I have a bad feeling about MR brain. I have a bad feeling about PET CT. If you can't afford a PET CT and an MR brain, you know what you can't afford? Taking all that goddamn osimertinib. Destiny Breast 6, I suspect that there may be some interaction between HER2 positivity and benefit. The company's going to do everything to try to hide that interaction. It's an investigator choice. Anything you want off the kids menu. Allowed anything off the kids menu. Palliative care study. Again, I have some quibbles. Evoke 1, it's stone cold negative. They didn't even go up against the real winner in that space. Nadina, lots of interesting things to look for. Transmet, it's a great trial if you're rich and have a jet and you can list yourself in multiple districts for your liver. It's not a great trial for lots of other people. And photons, protons, you heard it here. All right, that's what we're looking for. We're going to be back with the follow-up video and some other videos and some other stuff. Subscribe to...
Click and click.
Click and click. 2 more clicks. Many others. Stay tuned.
Subscribe to... One more.
That's right. The Drug Development Letter. drugdevletter.com. And I will be there at ASCO giving 2 live sessions, the critical appraisal of low-value care. They will be here, the Omni Hotel, 4 to 6 on Friday and 4 to 6 on Saturday. Come. We will try to accommodate you, particularly fellows, particularly people who want to learn. And we will get into lots of things, principles of oncology and more. So you don't want to miss that. All right. Thanks to Timothy for putting together these slides. Thanks to everyone for coming.
Thank you.
Let's do some questions if anyone has.